Thanks for the opportunity to come and do a little presentation this morning. So my role on this panel is I'm the academic researcher, and I'm going to serve that role very well because I actually have more questions than answers. I built this presentation based on the questions that we have and we hear, and hopefully I'll take from those questions and then get down to the things that I think are the places where we still need to look and still need some data. So I'll start with this one, and this is the question that we probably hear the most, right? Is, does this patient need an antibiotic? And it really doesn't matter if it's this patient or that patient. The question's kind of the same, and we like that question because the question has a binary answer. It's yes or no. And it's an easy question to, my new phrase is armchair prescribing. It's an easy question to sit back as a third party and go, yeah or no. This question lends very well to protocols, it lends very well to clinical practice guidelines, and we like all those things. But I think it's the wrong question. So I'm going to propose question 1B, which is this one. And the reason we don't ask this question is because it's a lot more complicated. So this question is it's the same question by nature. We have an individual patient and we need to make a decision about antibiotics, yes or no. But it starts to get into the dirty details of why stewardship is so hard, and that's because we're talking about risks versus benefits, and there's a whole lot of gray in the middle. So I'm going to take that question, and based on that question, this is what I think we need to do to start answering that question. So this is the hard part. So we need to have a defined acceptable risk. Just with an informal show of hands, who in this room would like to be part of the discussion when the decision is made about acceptable risk? Nobody? I sure want to be at the table when people are deciding whether I get antibiotics down the road or not, right? So show me your hands. I know it's early. So who wants to be part of that discussion? Okay, good. Keep your hands up. Keep your hands up. Keep your hands up if you want to be the person that draws that line in the sand. And the caveat is that line can't be zero, and it can't change when you or your child or your grandmother is the one with the infection. That's why this is hard. And we all have different acceptable risks, right? So Dr. Sybil here is at a different stage of his life than me. And I would assume that he probably has some stock. And I would assume that his tolerance for risk in the stock market is much different than mine, right? As a concrete example, it's the same with antibiotic therapy. We have different tolerances for risks based on where we are, our health status, how likely we think we have that disease versus something else that might really need antibiotics, and all of those things matter. And that's why it's hard. And so we're trying to balance all of these risks. We're trying to balance the long-term societal risks of prescribing antibiotics to an individual patient. And then we're trying to balance the risks to that individual, which could be, if I prescribe that antibiotic, that patient may have a very serious outcome related to the drug, which we'd want to avoid, which would be a negative. But we're also trying to balance what is the benefit of prescribing, and on the flip side, avoiding the negative outcomes of not prescribing. So this is a really, really hard question to answer, and I don't want to leave you with, I think this is almost impossible to answer, and we just throw our hands up in the air and quit and walk away, because I think that's what we've done for too long. So we may not be able to draw that nice, neat line in the sand as far as risk goes, but I think there are some things that can help us balance that equation out a little bit. My bias is diagnostics. I work in a diagnostic lab. My income is derived from diagnostics. But if you look at national action plans, both here in the U.S. and internationally, as people are trying to decide what stewardship looks like, diagnostics is always a piece of that. And the reason that diagnostics are so important is because they help us define the risk for that patient. The first one, so the detection of underlying resistance, that doesn't really exist right now as a diagnostic tool. But if we had the tool that we could use on an individual, that we could monitor their individual resistome. So how likely is, if I treat that patient, I'm going to select for resistance to that drug in any pathogen. That helps us balance out the societal risks of prescribing to that patient. And it does it on the human side, and it also does it on the veterinary side, because then we're talking about resistance moving through the food chain, and we can balance our therapeutics that way. The other role for diagnostics in kind of defining and balancing risk is in disease confirmation. If you talk to physicians, I'll say prescribers, because it doesn't matter if they're human or veterinary, the thing that always comes up in those conversations, they are concerned about the rare but serious consequence of not prescribing an antibiotic. And so if we have tools that assure the clinician that that patient has the disease that they really think that they have, and not some rare but very serious exception, they have more confidence in not prescribing an antibiotic. So there's a place, if you're in the diagnostic field, go out, make a path there, because I think there's great need. Adjunct and alternative therapies, I won't get into that a lot because I think Judson's going to talk about that some, but really what alternative therapies do is they take the balance and they throw it on its head, right? Because now we've taken away a lot of the risk for developing and promoting resistance if we have an effective alternative that doesn't promote resistance. So it takes the balance and just moves it all the way to benefit. So that's a nice, easy solution. And then, because of my other hobbies, the one that I want to dig into a little bit more today is optimal dosing. So optimal dosing changes the risk-benefit equation, not because we are or are not going to prescribe an antibiotic, because we've decided now that the patient needs it, but we might be able to refine it to change the balance a little bit, where I'm not selecting for resistance as much and I'm still getting the clinical benefits of a therapeutic. So that's going to take me into my second and final question, because they told me I only had 10 minutes. So the other question, and my side hobby, sorry I mentioned that, my side hobby is I'm a veterinary clinical pharmacologist. So I like messing with antibiotics and dosing and things like that. And so one of the questions that I kind of have and have played with over the years is there a balance in dosing where we can change the dynamic of we still get the benefit of a positive clinical outcome, but we reduce, not to zero, but we reduce the selection of resistance pressure? And so I'm not the first person to have this question. And this is the citation if you're interested in this full article, but I'm going to read this abstract just to give you an idea of where I think we need to go as scientists. So this is Dr. Radetzky's abstract. Oral antimicrobial treatment of acute streptococcal pharyngitis commonly is given for 10 days. An investigation was conducted of journal publication and textbooks from the dawn of the antimicrobial era to the present in order to discover the basis for this settled practice. So Dr. Radetzky was interested in why we give penicillin for 10 days for streptococcal pharyngitis and wanted to know where that recommendation came from. She did a very extensive literature search. What she found: the 10-day treatment standard evolved without scientific justification. There have been no therapeutic trials that have validated the necessity for 10 days of oral antimicrobial therapy. Yet, despite the lack of a scientific foundation, the rarity of acute rheumatic fever in developed countries, the high failure rate for streptococcal eradication, and evidence that short-course therapy with a non-penicillin antimicrobial yields equivalent eradication rates, the 10-day rule persists because of long clinical usage and the inherent power of the number 10. That's where our dosing recommendations are coming from. And the last line of her abstract is, efforts to change this clinical benchmark will likely meet with resistance from practicing physicians. Okay? So I have, again, the same question, and mine was not as extensive as Dr. Radetzky's, but I went through the literature to see if I could find evidence that would support either short or long durations of therapy. I did this search almost 2 years ago now. I started with over 600 articles, whittled that down to 7. There was one that I left out because it was an in vitro study. 7 articles that actually compared a short duration to a long duration of therapy. And they're graphed here. The short duration therapy is the hash bar for each study. The solid bar is the long duration. If you squint real hard, somebody tried to convince me that there's a difference between short and long duration of therapy. And this is for clinical success. This doesn't account for resistance. This is clinical success according to that study. Tell me there's a difference between short and long for any of those studies. No. I have a hard time finding it. I haven't done statistics on it, but just looking at the data that way graphically, I think you'd struggle to find that. So now I'm making an assumption that a shorter exposure, so less antimicrobial exposure, would translate to less resistant selection. And I think that's a fairly safe assumption, but it's probably something we should look at as well. But just from the clinical perspective, this pretty much supports that short durations of therapy are just as good or better than long durations. Now, to be complete, there was one study I left out. It wasn't the in vitro study that did show that long durations of therapy were better for short durations. It was for ear infections in children, but the study was really confounded among the treatment groups, and so although that was their conclusion, the study in my mind was flawed enough I wouldn't include it here. So it's not, the literature evidence doesn't 100% point this way, but it very strongly supports that short durations are adequate for treatment outcomes. So, and this one's pretty straightforward for me. What is the science? What is the data that we need to move forward? I think that we need to be willing to go back and, I don't want to throw away our history and our past science, but we need to challenge it and question it a little bit. We need to do what Dr. Radetzky did and ask the question, where does this recommendation come from? Does it make sense, and can we do better? And it's not just, I did duration, but I think there's also opportunities to do that for drug. There's opportunities to do that for doses, and there's opportunities to do that for frequency of dosing. The downside to that is each drug dose, duration, frequency, pathogen combination may be different, and so we have a whole lot of work ahead of us. So, am I doing okay for time? So 2 things real quick. I was made clear I had 10 minutes. 2 things. I think we need to go back and ask questions. Is what we're currently doing really based on good science? And when I go back to the risk question, again, that's a huge question to ask, and it's a huge question to answer. And I think one of the pitfalls with that is because we have so many scientists approaching that question from so many directions, those are all good efforts. But I think the risk is we don't connect those dots. And so bringing those individual pieces of data back together to look at, okay, how does that change my risk-benefit equation for a therapeutic or for antimicrobial treatment?